We start today. Hello, we are Rocío Rovira, Mehmet Setin Kaya from Turkey, and Carlos Fabres from Spain. We are members of the AO Spine Youth Club. Welcome to the Expert Insight series, where they interview worldwide expert spine surgeons who kindly share their professional and personal experiences with us. On this occasion, we present Dr. Ferran Pellise, an orthopedic surgeon trained at Vall d'Hebron University Hospital. He has dedicated himself to treating spinal pathologies, notably scoliosis and other deformities, and leading the spine unit at Vall d'Hebron and directing the Barcelona Spine Institute. He also serves as a professor at the Autonomous University of Barcelona.
Dr. Pellise served as associate editor of the European Spine Journal. He has had key positions in various medical associations focused on spinal diseases, including the Spanish Society of Spinal Column, Spine Society of Europe, and Scoliosis Research Society. He has been a member of SRS for 12 years, and he became at-large and secretary in 2018, the first European to hold such a position, emphasizing the Society's commitment to global expertise in spinal deformity care.
As the founder of the European Spine Study Group, Dr. has spearheaded to establish a comprehensive database on adult spinal deformities. This initiative, involving top European specialists, facilitates research, collaboration, and advancement in surgical treatment worldwide. The collaboration between European and North American centers, research effort leverages extensive patient data to improve surgical outcome and understand complications, especially in elderly patients. This interdisciplinary approach, integrating artificial intelligence solutions, enhances surgical precision and patient care. Good morning, Dr. Pellise. Thank you for accepting our invitation to the start interview. Before beginning, could you tell us your full name, specialty, and full current position, please?
Excuse me, could you repeat the question?
Yes, before beginning, could you tell us your full name, specialty, and full current position?
Yes, my full name is Ferran Pellise. I'm a spine surgeon with an orthopedic background. At present, I'm professor of orthopedics at the University Autónoma of Barcelona. I'm also responsible for the spine department at Vall d'Hebron Hospital, and I am also the director of the Barcelona Spine Institute in Hospital Quirón. I'm serving as secretary of the Scoliosis Research Society and had been the president of the Spanish Spine Society and the Eurospine, the Spine Society of Europe.
Okay, thank you, Ferran. Let's start with the questions, okay? Where did you receive your medical training, and when did you complete your residency? Could you outline the initial steps leading up to your specialization in spine surgery?
Yeah, so I became resident of the orthopedic department in Barcelona back in 1987, and I think it was like during my second year of residency or third year of residency, I was already very much impressed with the work that was being performed by the persons that were dedicated to spine surgery in Vall d'Hebron Hospital. And at that time, they were not organized as a spine unit as such, but there were some individuals, basically Professor Madrigal, together with Carlos Villanueva, Juan Bagó, and Jose Casamichana, who were independently but coordinated as well, they were doing spine surgery. A few years later, in the early 90s, they came together and they founded the spine unit at Vall d'Hebron. I was impressed with the work they were doing. I was extremely attracted by them, and tried as much as I could to join them and to collaborate with them. And this was my origins, or my first link to the spine surgery. Then I finished residency in 91, and then in 92 I became a general orthopedics. I did a lot of hip and knee replacements. I did general trauma for many years, And then in 95, I was asked to join the spine, or invited to join the spine unit that at that time was led by Carlos Villanueva. And since then, since 1995, I was dedicated exclusively to spine surgery. It's true that until 2000, I was doing general traumatology emergencies and was also taking care of femurs of any kind of trauma. But since 2000, I stopped doing trauma emergencies and was totally exclusively dedicated to spine surgery and mostly to spinal deformities. So I had a very close relationship with Ogeneba Boachia J from the HSS in New York. I was visiting him periodically, almost every year. I was visiting Ogeneba in New York, and in 2005, I became a volunteer of the Focus, which is Foundation, which is operating in Ghana, and I've been actively collaborating with Ogeneba Boachi in Ghana for more than 10 years. And I also visited other spine specialists around the globe, and this is how I just got most of my instruction or my learning in spinal surgery and mostly in spinal deformities.
Okay.
Okay, thank you. And as an experienced spinal surgeon, what advice would you offer to aspiring young surgeons considering a career in spine surgery? And what do you believe it's a rewarding field? Why do you believe it's a rewarding field? Or do you believe it is?
No, in terms of advice, it's difficult because everybody has to find its own path and its own way based on local on the local situation. You know that in Europe there's no a clear fellowship in spine already established. This is not included in our regulations. Some countries like UK do have it, but many other countries, mostly in the European Union, there's no clear fellowship. So this is going to come, I'm convinced. But at the end, the fellowship, which is relevant in other cultures, as US, I don't think is so fundamental because it only takes 1 or 2 years. So if you want to do spine surgery, I think what you have to do is to identify which are the units or services or departments who are doing good surgery, have good surgical departments. And I think it's also relevant that they should have also good clinical research associated, and then apply or try to join them, or at least visit them. I think it's extremely important to visit people to see what they are doing, how they are performing, both surgical and in clinical research, and try to join one of these groups. I think it's essential for a good clinical practice to have a good clinical research activity.
And what do you think? Do you think that in a period of a year it's a good time, or maybe 2 months just for visit these people in a short period of time? It could be enough, maybe.
So fellowship or visiting fellowship mostly is something which is going to be the starting point. But at the end, you have to establish somewhere, and you need to be established with somebody else. You need to work in a team. I think it's extremely relevant, or for me, it's been very rewarding to be able to work with a group or within a group of persons dedicated to the same pathology. And most of the times, people have different profiles and become very complementary. So first, you travel a little bit and you see different options. This could be included in the fellowship plan. You establish somewhere where you think there's going to be a good link, but at the end, you have to create your own practice, or you have to be included in a group which is already practicing. The period you have to circulate before establishing yourself, it's variable, it depends on the circumstances, but in many places it's between 1 and 2 years. But the relevant thing is continuous education. And then continuous education can be obtained through the group you're joining. If you are joining a very good and powerful group of specialists, you'll get a lot of education and you'll nourish yourself from this group of people you're joining. And then you can complete these educational and improvement activities by visiting other surgeons that can be a good reference for you and can also become one of your mentors. You need networking, you need mentors in different places. And I also think it's extremely relevant to be, as I mentioned, involved in clinical research, because once you are involved in clinical research, you generate questions. This is clearly improving and increasing the quality of your work. And normally you share the data, and by sharing the data in meetings and in conferences, you create again your network, and this is allowing you to grow, to improve your knowledge and mature as a professional.
Okay, thank you.
We expect our Spine Youth Club help us to get it. So in this respect, should young surgeon start as soon as possible in a spine unit, in your opinion?
I think it makes sense. So in my personal case, I did like general orthopedics for a period of 3 to 4 years, but I think it's good to focus on what you want to do as soon as possible. Things and our profession has changed a lot since I was a resident. It's much more clear now that orthopedics is too wide and you cannot cover everything, and you have to focus on a subspecialty. And if you want to focus in spine, this is a decision I think you should make not later than 2 or 3 years after finishing residency, and then be fully dedicated to that pathology. It's wide enough to concentrate. General concepts of orthopedics will always be needed, and mostly if you're doing deformities, I think it's extremely relevant. The other important thing, which I think most of the spine surgeons with orthopedic background, young orthopedic surgeons that want to become spine surgeons, they need now a very close interaction with neurosurgical departments, which at that time was not that common. But I think now we are working with neurosurgeons, both in Vallebron. The unit or department is multidisciplinary. We are 5 orthopedic surgeons and 2 neurosurgeons working together. And in the Barcelona Spine Institute, it's a bigger group, and it's also multidisciplinary with 4 or 5 neurosurgeons working with us, with 6 orthopedic surgeons. So I think it's very important, the interaction between neurosurgeons and orthopedic surgeons, and include people with different origins but fully dedicated to spine surgery.
Okay, thank you for the advice, Dr. Pellise. Let's continue. Reflecting on your journey, who has been the most influential figure in shaping your career as a surgeon? Maybe we said before.
I have. You always receive influences, and I'm still receiving influences. And I would say that in a very young stage, it was clearly the people from Vallebron, mostly Carlos Villanueva, Jose Casamichana, and Juan Bago as well, the three of them. Then I added Paco Sanchez Perez Grueso from Madrid, who's been also, I'm considering him one of my mentors. Then Ohene Baboachi played an extremely relevant role from a surgical point of view to understand properly deformity, to see exactly how to face and understand complex deformity. I think I did a great learning, and I'm always considering him as a mentor. And then as I've become older, I have had also good influences from other good friends. In the European Spine Study Group, I'm receiving a lot of influence, and I learn from Ahmed Alanay, I learn from Javi Pizones, I learn from Ibrahim Obeid, from Frank Kleinstug, now from Jean-Philippe Charles. I am also learning a lot from my colleagues in the International Spine Study Group, and clearly I have to name Chris James, who's somebody from whom I'm learning a lot. I'm learning from Michael Kelly. I'm learning from Munish Gupta. I'm learning from Cal Kebesh, from Larry Lenke. So I'm learning from a lot of people. I'm interacting constantly with them. So it's different because it's more transversal knowledge and learning. It's not so vertical, but there's a lot of people who have influenced me. And now I'm sitting at the board of the SRES and I'm learning a lot from all of them. Michelle Wellborn, I'm learning from Lindsay Andras, from David Skaggs, from Marinus de Kluver, from Laurel Blackmore. I'm learning from Serena Hu. I'm learning from a lot of people, from Eric Kleinberg, from a lot of them. And I seriously learn from them a lot.
Okay, and how do you approach mentoring trainees in your field? What's the most important thing you want to teach them?
Well, this is always a difficult question, and it's true that now I'm mentoring quite a lot of persons, and basically I think you have to transmit what you think is being advantageous to you. You can provide advice. You can teach them surgical skills as well, but I think it's more guidance, and let the people interpret and perform surgery based on their own skills, based on their own knowledge, based on their own vision. So you provide guidance, but at the end it's the individual who interprets and performs. And I think mentoring is basically providing guidance, providing advice. There's a lot of friendship in mentorship, a lot of friendship, and I consider myself a good friend of some of my younger mentors, and to mention two of them, Susana Nunez and Sleiman Haddad, who have been working for me for ages, and I think they are probably the most brilliant surgeons now in the scene in Spain, and they are extremely good friends of mine, extremely intelligent, clever, and skillful. So, but the relationship is, yes, I've been his mentors, I've been the mentor of them, but now I'm more of a good friend, and I provide guidance, but they also make their own decisions, and sometimes the decisions they make are different from what I advised, and quite often they are right. So they have so you just have to let them grow and let them decide and provide advice if they ask you to. That's it.
Okay. Yeah. I think it's important to show the way, but the way you must walk it yourself, no? And that's the Another question: can you share a particularly challenging case from your practice, and what insights did you gain from managing it?
This is constant learning as well, and this is why clinical research is so important. I think it's crucial. I mean, it's very difficult to have a high quality practice not being involved in clinical research, because each case has a question, each case has a learning. Good cases have a learning. You know, and you try to understand why this case was so good, and you deduce. And normally you check that, and it's already been described, and you confirm what's been described in your case, and you see why this case did well. So you have a learning here. And once you have a complication, normally you are not being the first having the complication. You check, and you also see the reason for this complication, and you learn. And sometimes there are some complications or some good outcomes that have not been properly described or are still not well perfectly understood, and this is normally where the good research is. So if you identify a good outcome or a good or a bad outcome or a complication, and you looked into the literature or what's been discussed, and you think it's not been properly understood, these are normally the good research questions. So you increase your understanding of this outcome, either good or bad, and you provide also some knowledge to the community. And this, I think this is basic for progress, is basic for individual progress, and this is one of the most relevant things I look for people I want to incorporate in my teams.
So with regard to this question, how has your involvement in research influenced your clinical approach to spine surgery?
Very much. Very, very much. I think it's crucial. And I would advise you that, and I think this is the most important thing. You will receive pressure from industry. You will be willing to innovate. You will be willing to jump into new technologies, endoscopic surgery. I don't know, things I'm just thinking now, seeing your faces. And you need to do that progressively and understand what you're doing, and assess your cases, get data, understand the data, analyze the data, and see how you progress. So research is extremely relevant, as I mentioned. Somebody who's involved in research, who collects data, who assesses the data, who assesses outcomes, is something who will have a quick learning, will have answers to the questions, and it's evident that you will always have good and bad outcomes in your career. It never gets to the point that you only get good outcomes. This is not true. You improve, obviously, your outcomes, but as you always will be engaging in more challenging cases, in more complex situations, um, you will always have something to improve. And to improve something, you need to have a good understanding and analyze what has happened in previous cases, and this is clinical research.
Okay. So, in your opinion, what are the biggest gap of knowledge in spine surgery nowadays?
Well, this question, I can answer you that, and I will answer you that, but I have to disclose that I have a big conflict of interest. I'm very much dedicated to adult spinal deformity, and to me now this is what I think the biggest gap in knowledge is. But I might be biased. I think my impression is that we don't have a good understanding of the aging population, and this is going to be an extremely big challenge for your generation. Populations in Western countries are aging. You will face in the near future a population with more than 40% of the people above 60 years. And people above 60 years will have pathologies that now are ignored and will become extremely relevant. And the understanding of aging is not good enough. And now, and this is why we cannot face properly the complications adult patients are doing after spinal surgery. And you know that in adult spinal deformities, we reoperate approximately 20-25% of our patients due to mechanical complications. And we still don't understand properly why these patients are doing complications. And I think that most of this lack of understanding is because we don't clearly understand the aging process. What's happening with aging? Aging has to do with failure of tissues to repair and has to do with tissue failure as such. And until we don't understand that, we will be very much behind the problem. So the problem will be before us. We will be operating the patients, persecuting the deformity, but without a clear understanding, we will also have to persecute and follow after the complications instead of being in front or in front of that. So aging is one of the biggest areas that need a better understanding. And the other probably is, I'm also having a good bias here, big bias, is cord injuries. Neurological and cord injuries are another big problem.
I had the opportunity to send your last conference in the Spanish Congress. I think it's important that new generation understood this point. So,
I did not hear your question. Did you, Rocio?
I just said that in the last Congress, Spanish Congress, I had the opportunity to listen your conference about this topic, and nothing. I'm really glad to know this point about.
Okay, thank you.
And new question: what do you think is the future of spinal surgery? Are robots coming soon?
This is a good question. I still have my doubts, which will be the proper place of some of these enabling technologies. I think they will play a role. Enabling technologies will democratize spine surgery, so they will allow a larger number of people to jump into spine surgery and will, generally speaking, make spine surgery safer, but robots are not a guarantee of safety. There's a big debate right now regarding safety with the use of robots. There are thousands or a high percentage of devices and which are not properly placed using robots. And we are always receiving cases from other institutions that have been operated using enabling technologies and the screws are not properly placed. So it's true that it's a good way to guide and to increase safety, but you still need a lot of basic surgical skills or principles that allow you to check that what the robot is doing is properly done. The fact that something is being done by a robot is not a guarantee that this is going to be correct. And the responsibility is still from the surgeon. And this has to be still understood, and we don't have an answer right now of which is going to be the final place of this enabling technology. I think they will have a place, but we still need to understand exactly which is going to be the place these technologies will play. Yeah.
Okay, but do you think that in the near future, new technologies as a navigation will be something extend here in Spain, maybe, or
Everywhere there is two facts. There is a lot of commercial pressure in using these devices, and also there is the false idea that this is 100% safe. And this is pushing people with less surgical skills to use that because they feel safer using the robot. And this is not 100% sure. So you have experience, I know perfectly, cases where you thought the screw was in proper place and it was not. All of you, I'm convinced, because we see the cases, so we know that. But it's true that at the time you were doing that, you felt safer because the robot was telling you the direction, was telling you the place, or the navigation was telling you the place. But this has certain inaccuracy that you need to control and you need to be aware of it. So my general advice is that what it should never happen is that you could not work without navigation, without robots. And this is happening. I have a good friend of mine working in the United States who was telling us the other day, he's chief of a big department in the States, and he was telling us that he had a phone call and that some cases had to be canceled in his institution because the robots or the navigation was not working. And these were simple fusions. And I think this is no good. So I understand you should be able to use the robot in some cases and improve it, but you should also be able to work and to do the surgery without the robot. We were discussing that the other day, and another good friend of mine and good senior surgeon said, well, Ferran, I think you are not right. Would you operate if without a bovie, if you did not have the bisturi, the knife, the bovie? And I don't think the comparison right now is totally correct. It's true that probably without electrocautery, without the bovie, I would not operate right now, but it's extremely difficult not having a bovie because there's so many bovies all over in your hospital that if one is not working, you'll get another one. But robotics are not still at that level. And until it's not totally generalized and clearly totally available, you should master both techniques. You should be able to place screws freehand safely. Maybe in 20 years, robots will be so spread and there will be so many robots everywhere that doing freehand would make no sense, but not at this moment.
Okay. Yeah. Okay. Next question. Which aspect of your work do you find most fulfilling?
Most?
Fulfilling. That you think that it's more something great for you? Something. What's
The
the
one
best
I
part?
enjoy the most? most challenging and I like the most spinal deformities.
The most challenging spinal deformities.
Yeah, this is what I like the most. This is what I enjoy doing.
Okay.
This is challenging me, and I enjoy doing. I like it. I like spinal deformity very much.
So share a belief you hold that is not widely accepted by others in your profession.
Excuse me?
The next question, if you can share with us a belief you hold that is not widely accepted by others.
Probably the belief which is not widely accepted by many people is that to have a good clinical practice, you need to have a good clinical research in parallel. And I strongly believe that. And I suspect that many people would think that this is not true, but I strongly believe this is a good, this is real. People having good clinical research do have good clinical practice. And to my understanding, it's difficult having a good clinical practice without some kind of clinical research.
Okay. And when comparing veteran spine surgeons with newer practitioners, do you observe any significant differences, positive or negative?
I think newer generations are always better than older generations. You will do much better than we are doing right now. I'm convinced. I'm convinced. So it's you have a better understanding of the modern world, but this has happened to me like 20 years ago. I had better understanding of the modern world compared to my early mentors, and I'm convinced that now Javi Pizones, Sleiman, Susana have a better understanding of spine today than and what's gonna come than I do have personally. I'm surrounded by extremely brilliant people, both in Barcelona, in Spain, and globally, who will do much, much better. Jennifer Bauer, Steve Wong, Michelle Welborn, Lindsay Andras, Javi Pizones, Susana, Sleiman, Jan-Philippe Charles, Chaglar Yiglor. They are extremely, extremely brilliant and will do much better than we have done. I'm convinced.
And do you think the previous surgeons or the new spine surgeons have the same insight in spine surgery?
Yeah, because all these names and that I've mentioned, and let's come to one of your um, Turkish colleagues like Chaglar. Chaglar is just brilliant. Chaglar is a brilliant guy. He has all the knowledge that we have generated, that all the generations have created. He has all this knowledge in his mind, and he sees the world differently. And he sees the world, the present world, probably better than I'm analyzing and seeing it. So Chaglar has a great, great, great future. Chaglar is already leading spine surgery in the world together with Javi Pizones, together with Susana Sleiman and all the names. So I'm extremely optimistic with all the people, young people involved and willing to and already working and providing knowledge and improving what we're doing. Absolutely, yeah. Full. As I told you, we were mentors. We've been their mentors. Now they are our friends, and we get a lot of information and we learn a lot from them. A lot, a lot.
Thank you. And Carlos.
Yeah.
Carlos.
Well, I will continue. Yeah. What
Question.
are What are the top 3 skills you believe every proficient spine surgeon should possess or cultivate? Just 3.
I think a good spine surgeon today needs to master freehand instrumentation. Crucial. Any of you should control perfectly freehand instrumentation, freehand placement of screws, devices. You should be able to do freehand safely, everything first. You should be able to master and control the canal perfectly. This is the second one, at least extradurally. You should be able to manage the cord at cord level, at cauda-equina level, and at root level without any problem or safely. And the second, you should be able to do wide vertebral resections safely. These are the 3 things I think are most relevant from a surgical point of view.
Okay.
So the wide variability treatment approach in spine surgery often makes it difficult to study. What advice would you give us in this regard?
So this is also dependent very much on which area of the spine you would like to do. If you want to become a deformity surgeon, I have probably more insight here, and I could provide more advice. If you want to become a minimally invasive degenerative surgeon, I'm not that good in that area to provide advice. But I think it's true that invasiveness will be progressively decreasing. So focusing on less invasive surgery makes sense. But first should be reach the surgical goals, and second should be reaching the surgical goals being less invasive. You should not change the things the other way around. We've seen cases of young surgeons trying to do minimally invasive with horrible outcomes. And it's better to do first the job you have to do and then become minimally invasive and try to reduce invasiveness once you master exactly the procedure you have to do. But this is gonna come. So you will be less invasive, you have more technology, and you will have more and more technology. Enabling technologies will also help you to be less invasive, but you have to master the concept. You have to master, and you should be able to go back to open and more invasive, having as first outcome, making sure that you only benefit the patient.
Dr. Russoli said us the same advice, gave to us the same advice that we need to get the goal of the surgery. So let's conclude with a rapid fire round. Do you have any shortcoming that you think you need to improve?
Yeah. Probably my shortcoming is I should be more open to the inclusion of new enabling technologies. I'm doing my efforts here, and I'm improving in that, and I see the benefit. I still rely too much on my own feelings, palpation, freehand technique. I have my own orientation, and I think I should probably rely more on the enabling technologies. I'm generally very critical with new technologies that have not been proved, and I have a tendency to avoid whatever comes from commercial pressure. And this is the first one. Second, unless somebody has done a lot of clinical research, strong opinions from others, if not really based on data and just on gut feeling, I have a tendency not to rely on that. I like the data, but you have mentioned some names who are of people I've met some people who are extremely, extremely intuitive, even not having good data. And this is also something that you have to be able to recognize. You have excellent people who are extremely intuitive and you would rely on them. But yes, I have a tendency not to believe so much and to accept positions of people who are not very much involved in clinical research. Yeah.
If you were not a spine surgeon, what profession will you pursue?
I don't know. I think I don't know. I think I did the choices very early, and I'm extremely happy of the choices I made. I decided to become orthopedic surgeon just a few months before doing the mid exam. I was lucky enough to access to the first. I became the first orthopedic surgeon of that year, and so I got the first mere number for orthopedic surgery when I did the exam. I went to the site to the place. I decided to go to Vallebron, and I think this was a perfect choice. Then I decided to join the spine unit, which I think was also a good choice, and I've been involved in that unit since then. And it's difficult for me to see a different life. I don't know. I can't really answer you. I don't know what I would have done instead of spine surgery. No.
Okay, and what are your future aspirations and goals within spinal surgery?
This is a good one. This is a good question. I think I have modestly contributed to the growth of spine surgery in my country, and I've also contributed to the efforts at continental level by providing my input and collaborating with Eurospine. I would like to see a more mature spine surgery in Europe. I would like to have spine surgery become really a subspecialty from people coming from orthopedics and neurosurgery. I would like to be able to make spinal deformity more relevant, and I would like to contribute as much as possible in a better understanding of adult spinal deformity. This is what I would like to do. Yeah.
What do you consider your greatest strengths and weaknesses are?
Weaknesses. I've learned to be more open-minded with the years, being older. But I think this has been probably one of the main problems. People and myself, I've been too focused, and I think it's good being more open-minded. I still feel that some basics are needed for me to understand and to increase relationship, and one is clinical research. This is but having an open mind, I think, is something I would have liked to have it wider. And regarding strength, I think I have spent a lot of time dedicated to the development of my profession. And just to tell you, I think most of us, and me particularly, I've been working all the days of the week for the last 40 years. I work on Sundays, I work on Saturdays. I'm always involved and dedicated at least 4 or 5 hours a day to any spine related issue. either writing papers, either reviewing articles for journals, either involved in societies, either involved. So I've been in that aspect. I've enjoyed dedicating myself and dedicating time to my profession. And in parallel, I've been able to enjoy my family life extremely. I have what I think is I would say, it's difficult to say, but a perfect family. With my wife is a scientist a lot as well. She's a very good neurologist. She's listed in the 2% list of from Stanford of the most relevant clinicians in the world. And I have 3 children who are extremely brilliant. And I've been able to do my profession, sharing my family time with them, and this has been a great joy for me up to now.
Okay, and what was the last valuable lesson you learned on the job?
Excuse me?
What was the last valuable lesson you learned on the job?
There is a sentence which is true, which is that nothing challenges your confidence most than long-term follow-up. And this is true. What you thought was perfect several years ago, you see it and you revise it, and it's not that good. And there's always room for improvement. And it's true that you see cases that were done like 20, 30 years ago that still are perfect. But you also see what at that time you thought was perfect, and now you realize was not that perfect. And this is something that you learn with time, because you know the case, you still have in your mind when you operated that patient, you felt that this was an excellent outcome. And when you revise that, or the patient comes back to you 30 years later, you say, my God, I was convinced that was the perfect surgery. And in fact, it was not.
Mm.
And this is something you learn with time. Yeah.
Could you please describe yourself in one word?
Spine.
Okay. Thank you, Dr. Pellise. Thank you so much for joining us today and for being a source of inspiration and motivation for young surgeons or for AO Spine Youth Club. Your insights have been invaluable. Thank you very much.
Thank you very
Really
much.
enjoy this time.
Thank you very much. Thanks for the interview. Thank you very much. Thank you very much.
Okay.
Thank
See
you.
you, Ferran. Thank you.